Welcome to Crack Surgery, guys. Today we are going to discuss a very important topic, that is rectal prolapse. As we know, prolapse of the mucous membrane or entire rectum outside the anal verge is called as rectal prolapse. This condition is commonly seen in children and elderly patients. There are two types of rectal prolapse, as we know: partial prolapse and complete prolapse. ठीक है. Etiology: decrease main etiology factor is decreased sacral curvature and decreased anal tone. These are more prone, probable cause in the infant. In children's, there is a diarrhea, cough, malnourishment. Is risk factor in children's for the prolapse of the rectum. It may be due to reduced ischiorectal fossa fat, neurological causes, fibrocystic disease of pancreas, or poorly developed pelvis. In adults, especially in the females, common in multipara, repeated birth injury to perineum result to damage the perineal nerve supply, which can cause further rectal prolapse due to decreased tone of the air. It is due to weakening of supporting tissue, levator muscles, atony of the sphincter, increased intra-abdominal pressure due to any cause like chronic cough or stricture urethra. Now, partial rectal prolapse. Here, only mucosa and submucosa of the rectum descend down. Only mucosa and submucosa of the rectum descend down, म्हणजे comes out per rectum per anal canal, not more than 3.75 centimeter. This is no descent of, there is muscular layer. As we know, there is a mucosa, laterally there is submucosa, then circular muscle, then the circular muscle, then longitudinal muscle. ठीक है. In anal canal there is a mucosa, submucosa, internal sphincter and external sphincter. Here only mucosa and submucosal layer descend down and muscular layer is not descending here. That's why we call here partial prolapse. The prolapse should not be more than 3.75 centimeter, or it may not be more than 3.75 centimeter. It is a common type of rectal prolapse, as we know. There is a clinical features here. There's mass per annum which can be observed when child allowed to strain in squatting position. It is a pink in color and circumferential, when the whole circumferential descend down. As hemorrhoid, there is a o'clock position, that is 3 o'clock position, 7 o'clock position. There is a partial descent of mucosa. Here there is a complete circumferential descent. It differs from the piles. It is the differential piles are not circumferential and plum or blue colored, not pink, because there is a venous congestion. As a treatment in infant and young children, digital reposition. Only digital reposition can prevent this disease or improve this disease. The parent are taught to replace protrusion and any underlying cause are addressed before. Submucosal injection. If digital reposition fails after 6 weeks of trials, injection of 5% phenol in animal oil are carried out under general anesthesia. As a result, aseptic inflammation following this injection, the mucous membrane become theatre to the muscular cord. After injecting the sclerosant agent, the mucosa fibrous, there is a aseptic inflammation. ठीक है. There is aseptic, sterile inflammation happens there and fibrosis occur. That's why mucosa adhere to the muscular layer, muscle coat. If this generally surgery, occasional surgery is not required. In such cases, children are placed to prone jack position. Retrorectal space is entered and rectum is sutured to the sacrum. In adults, if there is partial prolapse, local treatment, that is submucosal injection as sclerosant agent are used. Excisional of prolapse mucosa when prolapse is unilateral, means once. Redundant mucosa can be excised if circumferential or endoluminal stapling technique can be used. complete rectal prolapse. As we know, the prolapse, there is a descent is more than 3.75 centimeter. It contains all layer of rectum, that is mucosa, submucosa, and muscular layer. Yes, ठीक है. Okay. Complete rectal prolapse is also called as procedentia, less common than partial prolapse. It commonly seen in the female. The female to male ratio is 6 to 1. It is due to weakened levator ani and supporting pelvic tissue. Generally, there is a defect in the levator ani muscle or pelvic diaphragm which can cause the complete rectal prolapse. The descent is always more than 3.75 centimeter, contain all three layers of rectum, often descend down up to the 15 centimeter, 10 to 15 centimeter, is often associated with uterine descent or uterine prolapse. Yes, it often associated with uterine prolapse. Uterine, both are together entity. Together we see once every in female every complete rectal prolapse should be examined. There is a uterine prolapse present or not. Once it also thought to be intussusception of the rectum. Once a complete prolapse is more than 5 centimeter, anteriorly drags the peritoneum as a pouch, often contained in small intestine. On digital pushing, it reduce with gurgling. As we know, upper part of rectum is covered with the anteriorly and laterally with peritoneum, and middle part only covered with anteriorly, the peritoneum. When this prolapse happen, this the peritoneum is attached to the wall of the rectum. So when the rectum descend down, it peritoneum also descend down with the pouch of Douglas, which also comes down. This pouch contain the small intestine. These are the intestine which also descend through the rectum through this pouch. As we try to reduce it, it will reduce with gurgling sound. Okay. E- Etiology factor, as we discussed, there is a weak anus, external sphincter or pelvic muscle, lax or mobile rectum muscle, obturated anorectal angles, abnormality, mobile rectum with descent. What is the clinical features? It happens in complete rectal prolapse. Complete descent of the rectum is red in color, often painful because it is cross the dented line as and mass per annum. Fecal incontinence is very common. It is disrupted of anal sphincter, prolapse, rectal mucosa, discharge, pain per annum, bleeding can occur because of congestion, sepsis, discharge, this mucosal discharge maybe, fever, anemia, or other features. If severe PR bleeding maybe happen, that's why anemia is there. PR examination so lax sphincter, anteriorly peritoneum sac comes down as a pouch which make contain small bowel, as earlier I discussed. Mm, Investigation in complete prolapse. First, main is defectography, reveals the increased mobility of rectum from the sacral fixation point with redundant mesorectum and funnel formation. It is fluoroscopic and spot filming in lateral projection. After instilling radio opaque material into the rectum done in sitting posture over the radiolucent comid. Second is cinedephydography. Cinedephydography is a triple contrast cinedephydography. Dephydography. Dynamic MRI. And lastly, main important sigmoidoscopy. Anal manometry is most important, and a pudendal nerve latency study should be done there. Treatment is surgery is always surgery is main treatment. Operation can be performed via perianal region and abdominal approach. There are two approaches. One is perianal, second is abdominal approach. Abdominal rectopexy has lower rate of recurrence, but when the patient is elderly and very frail, perineal option is indicated. Abdominal procedure risks damage to the pelvic anatomic autonomic nerve system, resulting in the possibility of sexual dysfunction. Perineal approach is also usually preferred in young male. First is Theus stitch. This Theus operation. This procedure is aimed to place steel wire or more commonly elastic or nylon suture around the anal canal, which become absolute. The reason is it lack property where that the suture is often break, cause chronic perineal sepsis or both perineal stenosis. So created would produce severe functional problem. Denorming operation is now preferred perineal approach. What is Delorme operation? In this procedure, rectal mucosa is removed. Rectal mucosa is removed circumferentially from the prolapse rectum over its length. The underlying muscle then plicated with the suture in such that when these are tied, rectal muscle are concerted towards the anal canal. Anal canal mucosa is often sutured with circumferentially to rectal mucosa containing at the tip of the prolapse. Prolapse is reduced, ring of muscle is created above the anal canal, which can prevent a recurrence. Simple. What happens when there is a descent down? What happens at dented line? The mucosa, submucosal layer, and are removed from here, and the muscle fibers are plicated here with the suture above the dental lines. So there is a fibrosis of muscle happens there. Is a fibrosis of muscle happen there. Aldermeyer's procedure. This consists of excision prolapse of rectum associated with sigmoid colon, constricted colon, coloanal anastomosis. It consists excision of prolapse rectum, whatever the prolapse, it is complete excise. In Delorme, only mucosa and submucosa excise. Any there is plication of the muscular layer done. In Altimeter procedure, there is a complete excision of the rectum associated with sigmoid colon from the below, and coloanal anastomosis is done. Here all the layer is cut and direct coloanastomosis is happen here in ultimate position. In renormal position, only mucosa, submucosa, prolapse mucosa and submucosa are cut, and muscle is plicated above the dentate line. Here all the layers are cut and coloanastomosis is done. Abdominal approach is principle of all abdominal operations. Rectal prolapse is replace and hold the rectum in its proper position. Main principle: the hold the rectum in its proper position. They are recommended in patient with complete prolapse who are otherwise in good health condition. Many variation has been described in Wells operation. The rectum is fixed firmly to the sacrum by inserting sheet of polypropylene. As seen in image, polypropylene mesh is in between them. Placed Ripstein operation involve hitching up with the rectosigmoid junction by Teflon sling to the front of the sacrum. Many surgeons simply sutured the mobilized rectum to the sacrum using 4 to 6 interrupted non-observable sutures, so called as suture rectopexy. This technique has been performed laparoscopy, thus reducing the operative trauma and limiting the time of hospital. Simple. There is a dissection of pelvic region, and the rectum is fixed to the sacral by suture or a Teflon sheet or mesh placed which wrap over the rectum, and the end of this mesh are sutured to the posteriorly to the sacrum, so there is no descent of the rectum happen. It fibrous and attach rectum to the sacral curvature. The, when it used with is done with suture, it causes suture rectoplexy. The complication as well injury to hypogastric nerve, causing incompetence, bladder dysfunction, bleeding. There is a main bleeding, so the sacral vein inspection, injury to rectum, cause colon causing fecal fistula, constipation, recurrence of prolapse, improper correction, continuance in 50% of cases, infection maybe cause the. Okay, thank you.